We'd like to felicitate our respected principal ma'am for her dedication and invaluable contribution to this institution. I would like to invite Dr. Shahid Bashirwani, Associate Professor and Head of Radiation Oncology, Dr. Mohammad Ashraf Tili, Ex-Professor and Head of Radiation Oncology, Dr. Arshad Hussain, Siddiqui, Medical Superintendent of GMC Medical College. Please felicitate our principal ma'am.
MR had a limited role in the past, however there have been major software as well as hardware and advancements in MRI, and they have improved the diagnostic performance. The advantages, it has the added advantages of superior soft tissue contrast with radiation, without radiation related risks. Several meta-analyses have revealed that the overall accuracy in the T and the N stage assessment is better with MRI than CT. MRI is also an efficient tool for the diagnosis of the distal mets, especially for the liver lesions, which are very often difficult to be picked on a routine CCT. So MRI is the hepatobiliary contrast agent, especially useful for lesions less than 10 mm. Coming to the role of diffusion. The diffusion imaging has been a major impetus in increasing the utility of MRI in the gastric CA imaging. So diffusion has to be considered a useful tool for the evaluation of the peritoneal dissemination. In fact, studies have demonstrated that the accuracy of T2 weighted images with diffusion weighted imaging with dynamic contrast imaging is definitely better if we use the T2 and the contrast images only.
It's a very well-funded registry. We are getting a lot of staff, 20-25 people are working on collecting this data, then tabulating and doing every sort of thing related to cancer. So it has been already discussed by my predecessors, Professor Ashraf and Dr. Shahid spoke a bit about it. Are these gastric cancers and esophageal cancers really most common in Kashmir? The answer is that it's a conflicting data so far, whatever we have seen. For example, if you talk about GMC Srinagar, they have reported here on something like more than 5,000 cancer patients. What they have seen is, you can see these on the right-hand panel, they have seen gastric cancer is just really the #1 cancer, and then esophageal cancer comes number 4. This is from GMC Srinagar. If we talk about GMC Anantnag, you have presented, I missed those 2 slides, but you have published this. You see also stomach and esophagus as #1 and #2. Where back in 2012, I myself published a paper of more than 8,600 cancer patients data. What we found those days is that esophagus and stomach are really the top-notch cancers, and cancer esophagus was actually the #1. But hereupon, I would like to focus on a very important key factor. We say stomach is #1. Since we are running the cancer registry, there is an ICD coding system to that. What the data has been presented in Globocon so far and all over the world across all countries, they have combined adenocarcinoma SIVER2 and SIVER3 with stomach. That is why if we combine stomach with GE junction adenocarcinoma, it will clearly be the #1 cancer. That can we segregate the treatment of adenocarcinoma of esophagus and adenocarcinoma of GE junction from the squamous? Because most of these trials have combined different diseases. Squamous is a different disease, adeno is a different disease. Their epidemiology is different, their pathology is different. But the treatment has been kind of on the similar lines. Can we segregate that?
I think it's evolution of therapy for upper GI cancers, and I'll be concentrating mainly on adenocarcinomas. Gastric cancer generally, as you can see here, is treated with surgery. You resect it, depends upon the location, extent of the disease, you will resect that part of the stomach. But when we do surgery, how many of our patients are cured or live long enough? Unfortunately, despite the fact that half of the patients with upper GI cancers have a curable disease at presentation, the 5-year survival is only 20 to 30% in esophagus and gastric CA. And around 36% of them will recover even after aggressive local therapy. So that means we are not doing a good job. This is a graph which shows you what actually happens in gastric CA. If you see, you go beyond 2A and majority of them are dead before 2nd or 3rd year of the treatment. So we are not doing well with surgery alone. Surgery alone is not adequate treatment of upper GI cancers. So what can we do? We have a few things in our armamentarium. We can do a few things, and you must know that one of them is radiation. And I'm happy that there's a radiation oncology department coming in this part of the our place. It's very much required. We need many more radiation oncology equipments. The radiation department in SKIMS works almost 24 hours a day, which is not adequate.
और उसमें ऐसा है कि जो हमारे नेशनल प्रोग्राम्स हैं, नेशनल आजकल जो नेशनल नॉन कम्युनिकेबल डिजीजेस है, उसमें ये डिटेक्शन ऑफ कैंसर इज आल्सो गोइंग ऑन. NHM इसमें बहुत पैसे खर्च कर रहा है. तो पब्लिक अवेयरनेस इज वेरी इंपॉर्टेंट. इसमें पब्लिक को बताना है कि अर्ली साइंस ऑफ कैंसर क्या है. सपोज लेडीज में विल हैव इनको बताना what is the importance of breast examination, self breast examination, annual mammography करनी है, या perhaps it is very easy to do, ज़्यादा मुश्किल नहीं है, but उस needs pathologist में भी हर जगह available नहीं है. तो what we'll suggest to general public कि at least एक annual checkup होना चाहिए हर किसी का, जो complete body profile हो जाए, ताकि मतलब वो अर्ली स्टेज ऑफ कैंसर. बाद में वो अल्ट्रासाउंड कराते हैं काफी लेट से 2 साल 5 साल के बाद, लेकिन उस टाइम बहुत देर हो चुकी होती है. सो इट इज वेरी इंपॉर्टेंट दैट वी lay emphasis on prevention rather than cure. This is one aspect. बाकी है हमारा जो डिपार्टमेंट है, सर ने बोला है, डॉक्टर हमारे शाहिद साहब ने, तो फिलहाल डे केयर है. फिलहाल हमारा रेडियोथेरेपी इज गोइंग ऑन, कीमोथेरेपी इज गोइंग ऑन. तो पैलिएटिव प्रोसीजर्स आजकल हम कर रहे हैं, ब्लड ट्रांसफ्यूजन, एसाइटिक टैप वगैरह. तो अभी हमारे पास कोई रेडियोथेरेपी यूनिट नहीं है.
Good afternoon to everyone present over here. It's my proud privilege to welcome you on the inaugural session of a one-day CME, which has been held in the Department of Radiation Oncology. And the topic is very important, the malignancies, multidisciplinary perspectives. So I would like to congratulate Dr. Shahid for coming up to my expectations. This is his first CME, so big round of applause. So it's a bit of, pull and push from my side. So we'd expect much better, CME in future. So respected faculty members, we have guest from Professor Shah Salim. Although I have not worked with him, but I know he's a known personality in radiation oncology. Then Professor Telisa, HOD from SKIMS, then Professor Ashraf, and other faculty members and their students. Why do we organize these CMEs? It is so that we know what is happening overall in different institutions and we can improve our own setup. I have a huge experience of working in malignancy cases. Like I have anesthetized so many of cases, and sometimes as anesthesiologists we say that the surgeon has written labro and proceed. Sometimes we say labro means we will see what is happening inside, and proceed means after that there will be a big surgery.